Welcome back, everybody. In this lecture, we're going to be actually exploring our very last branch of psychology that we'll be discussing throughout the semester. We're going to go down a number of different avenues when discovering this area. So it's not like this is our last lecture, but what we will be doing, hopefully, in this presentation is providing you with the framework of what this area of psychology that we call clinical psychology is. We're going to focus our attention in this class primarily on the clinical health concepts that really dominate this field, but I do want you to understand that there are lots of branches to clinical psychology that are out there, and if you're interested in this topic, I strongly encourage you to go through the readings and potentially even explore what some of the clinical psychologists in our school do so you can have a better understanding of some of the nuances to clinical psychology that are out there that maybe aren't always covered in an intro to psych class. But in this lecture, we're going to focus our attention on how individuals with mental health problems are helped through this topic that we call mental health approaches. Now, what does it mean when we talk about helping individuals with mental health problems? More often than not, when people come into an intro to psych class, they tend to think that anybody seeking therapy tends to have some type of diagnosable disorder that needs to be fixed. There are a lot of problems with that type of thinking. One, the implication that everybody seeking therapy has some type of diagnosable disorder is a misnomer. Two, this notion that people who have disorders need to be fixed is also a misnomer. More often than not, what we see in clinical psychology is, just like with personality psychology, a wide range of mental health capabilities and issues that people might want to seek therapy for. So when we talk in this class about therapeutic approaches to clinical psychology, and when we talk about different health disorders, what we want to identify is that there are indeed diagnosable disorders that clinicians use, even though we're, as we're going to talk about later, trying desperately to transition away from just categorizing people into having something and not, because it does give this odd impression that we essentially break and need to be fixed when we have a disorder. There's not a lot of evidence to suggest that that's the case. But we will talk about how sometimes therapists help individuals with these disorders. But we'll also talk about how oftentimes when people seek therapy, they maybe don't even qualify as having some specific type of diagnosable disorder in something called the DSM, or the Diagnostic and Statistical Manual of Mental Disorders, and instead they're struggling with some type of undesirable behavior or abnormal thought that they really want to address. It could also just be wanting to talk to somebody about some of the things that they're encountering in their environment that they're struggling with, that they would really like some assistance with. So we're going to go down a lot of different avenues about what today's clinical psychology is and some of the different ways that we can help people in the field who do manifest either specific symptoms or have things that they want to be assisted with. But before we do that, I think it's important to get some historical perspective on where clinical psychology came from and how it evolved over the century or so since it was introduced as kind of an approach to psychology at the same level as, say, cognitive psychology or behaviorism or any of the other branches of psychology that we've discussed thus far. And if we're going to go back to talking about mental health issues, we do have to, if we want perspective, to go back a considerable way. Most researchers looking at mental health have consistently found that almost every culture that we've ever had as human beings has had individuals that have displayed undesirable thoughts or behaviors. And they've tried to attempt to figure out what it was that was the source of these issues. Now, most cultures tended to lean on some type of spiritual or supernatural factor that they argued was behind a lot of the peculiar behaviors that people were displaying. And that meant that when they tried to help individuals with these problems, their treatment options, their attempts to remove the problems, also focused on the spiritual or supernatural. And it led to some very gruesome and odd approaches that had persisted actually for numerous decades or centuries, depending upon the culture that we're looking at. Trepanation, the attempt to drill holes in the heads of individuals, has been found in multiple cultures as a pseudo attempt to potentially allow demons to escape or kind of get rid of some of the stuff that people believed was found in the brain of individuals struggling with mental health issues. Exorcisms, which is oftentimes tied to Catholicism and the kind of supernatural belief that Christians had for many years around mental health, has also been found in other cultures in different forms. Many groups tended to try to find kind of weird medical or spiritual ways to help individuals with manifestations of a multitude of different symptoms, often relying upon leaders within medicine or within the health areas of those cultures. And in fact, terms like hospitals, something that was found back in the Egyptian time, were often used to describe the attempts to bring people to places and treat them with all of these different maladies that, again, have been around for centuries as we look at human beings and kind of the development of humans as a whole. And this focus on the spiritual and supernatural is something you can actually study in a history of clinical psych class or even a history of psychology class. But I want you to note that around the 1600s, we did, as a society across Europe, America, a number of different places, start to transition our take on maybe what the source of mental health issues were. Eventually, in the late 1600s, a concept called the somatogenic hypothesis started to be pushed around all of Europe and in some of the neighboring countries that had European influence on it, that surmised that mental health was not really something that was linked to spiritual or supernatural factors, but instead it was a byproduct of these things that we had just discovered called germs and illnesses that those germs and other things carried. It led to the development of new types of hospitals. Notice the word hospitals is in quotes there, that attempted to try to take advantage of this new somatogenic hypothesis by limiting the mental health issues that people had by separating those out in society that were displaying these abnormal thoughts and behaviors from everybody else. This led to many of the hospitals essentially just being prisons for the homeless, the mentally unstable, or just people that were considered undesirable by our society. And oftentimes these people were chained up in cages and left there for the majority of their lives with this persistent argument that they were incurable, they'd caught something, and they should be left alone lest they spread whatever they caught that caused a lot of their mental maladies. It is kind of interesting when we think about how this transition to medicine for many centuries has been celebrated. Yet there is this side effect that we see here where we knew a little bit about cells and biology in the late 1600s, but not enough to understand the folly of this somatogenic hypothesis that persisted actually for over a century. In fact, it wasn't until the late 1700s when individuals at numerous areas started to question this idea of the somatogenic hypothesis. Most people source back a real strong push against this idea to a theorist slash, I don't know if we want to say clinician, named Philippe Pinel, who in 1783 took control of the Parisian hospital system in France and started to tinker with the structure of their hospitals and challenge whether or not individuals within his hospitals should be separated from others. He did the daring thing of having people actually go into these cages that people had been locked away in for sometimes years and interact with them, trying to help them, trying to kind of talk them through things and figure out if they could maybe find a way back into society and, to Pinel's main point, see if interacting with these individuals really did cause these mental health issues to spread. And when multiple reports started to pop up of very little transmission of mental health issues when these people were around others, be it people taking care of them or family members, it led to this question of whether or not there was much merit to that somatogenic hypothesis. And eventually, about 100 years later, the world was kind of ripe for the picking when Sigmund Freud started to push his psychodynamic theory that we talked about earlier. If you recall, Freud's focus was not only on maybe what allowed individuals to be different from each other, the roots of personality psychology, but where some of the more obscure, quirky behaviors of individuals came from. His insistence that childhood and traumas and sexual focuses were the roots of many people's mental health issues really flew in the face of lots of theorists looking at these concepts of mental health for many, many centuries. And it eventually ushered in a new era where people started to support this new model of mental health called the biopsychosocial model, which suggested that many people who were displaying abnormal behaviors or thoughts were not doing it as a result of some airborne illness, but instead an interaction between their biology, be it their genetics or brain or some other structure that could be linked to the mental world, their psychological components, which usually dealt with their stress and the ways they were interpreting things, and social components, the stresses and the world around people that sometimes bring out certain types of symptoms. And this new model grew in popularity and shifted as successive generations looked at where mental health was coming from and how to best help individuals with a multitude of different problems. There were numerous cultures and groups that tried to kind of twist and turn this idea in different ways to better understand some of the social factors and things that could be the source of the emergence of mental health issues at numerous points in our life. One of the more common terms that starts to be discussed in the mid-1900s was this thing called the diathesis stress model. That suggested that many of us could have the likelihood of a different mental health issue emerging if we encounter enough stress and problems in our life. But we can also, to better understand who's more inclined to display these issues, look at a person's what's called diathesis, their biological predispositions, be it genetic or biological structures within the brain or other kind of physical components that could not only lead to somebody having a higher chance of developing mental health issues, but maybe a higher inclination for developing specific types of mental health issues. This kind of development of thought and where problems are coming from was paired with a development and change in thought of how to help individuals with a multitude of different issues. If we go back a number of centuries, what we see is lots of the approaches to try to treat individuals with mental health issues were again focused on the spiritual nature of things. But as we started to transition to biology potentially being linked to mental health issues, a lot of early, what we might call clinical psychologists, focus their attention on the biological things that we could potentially change in an individual to help them with a wide range of different problems. One of the odd things that started to become more prominent in the 1600s all the way until actually the early 1900s are these things that we call psychosurgeries. It's based on the notion that when we look at the illnesses that are causing issues, or the mental problems even that are causing issues, they're rooted oftentimes in the brain. So if we change the structure of the brain, if we try to kind of alter the way somebody's body is functioning, we could potentially alter the functionality of the symptoms that people are manifesting. This led to, as you can see imaged here on the right, the introduction of things called lobotomies, where theorists or medical individuals, we could call them, would go into a person's nasal cavity and reach up into the brain and cut off different sections that they surmised could be linked to mental health issues. A lot of this was more or less just closing your eyes, snipping off what you could, and hoping to see some type of results. And it also led to the introduction of something called electroconvulsive shock therapy, where people would take large amounts of currents, pass them through the brain of an individual, and hope that somehow by doing this, they reset the brain and recalibrate things so that a person can function in a semi-more functional way. Obviously, there's a lot of issues with these approaches, the undue harm that they can be done, the lack of scientific rigor behind them. And these things were kind of recognized even when they were being used on a regular basis. They were sort of considered last gasp options for people who were struggling but desperately needed to be fixed and get help. Obviously, we tend to sensationalize these things and suggest nowadays that anybody back in the 1700s that had problems would go in and have a big portion of their brain lopped off to try to help them. There's not a lot of evidence for that, but what we do see is that these things were semi-common, especially in more severe cases and cases where we had more, I guess, control over the individuals that were seeking help or being forced to seek help for a multitude of different problems. And if we're looking at these from a scientific perspective, there was, I guess, some efficacy to both of these. But many people suggest that the efficacy is primarily a byproduct of either just this kind of hope for these things popping up. We tend to call this the placebo effect, or a byproduct of people desperately wanting not to experience these things again, so they did their darndest to kind of keep their symptoms and problems either in check or just hidden, so they didn't have to undergo these types of interventions for a second or third time. If you're wondering, nowadays we very rarely would ever see these things popping up. ECT in smaller forms has come back as a discussion topic for helping with things like depression and other things, but it's got a different, I guess, nuance to it. We're definitely not talking about passing large amounts of currents through people's brains, and this is not a suggested approach for most individuals. It's kind of a fringe topic that people have explored on their own oftentimes nowadays. And lobotomies are certainly not just done randomly. The only cases where these things are still happening is if we can find a real tangible problem in somebody's brain that can be removed through some type of psychosurgery. But, overall, these things have gone by the wayside. And when we talk about biological treatments nowadays, we tend to focus on other things that have popped up in the last 100 years. We're looking at the biggest thing that's become prominent over the last couple of years, well, 50 years or so, when we talk about treating mental health issues, it's medication. And medication operates on this premise, much like the other things that we've talked about, that there are some type of biological components that are the source of mental health issues that people are struggling with, be it some type of diagnosable mental disorder or just some type of cognitive functioning that somebody desperately wants help with. And that assumption that there's some type of neurochemical or cellular cause to the problem leads to the obvious conclusion that if that's the cause, well, then the best fix is to just correct those cellular or neurochemical issues. When we look at medications today, there's a wide range of different medications that have developed for different types of mental health issues. And more often than not, what we see with these medications is that many individuals who start to take them with a wide range of issues tend to report a cessation of a lot of their symptoms. But it's also important to note that these medications attack a lot of different things, not necessarily always just the symptoms that somebody wants to have help with. But the fact that these things are very fast acting, they do hit a lot of different things, and they tend to persist in their efficacy for a long period of time, has led a lot of individuals down the path to really celebrating medications as the fix for a wide range of mental health issues. But many people in the clinical community have argued that that is kind of fictitious thinking that we really need to find a way to get away from. One of the big issues that many people pushing against this argue is that when people start taking these medications, it gives them the suggestion that the cells, the chemicals in somebody's brain, were the source of mental health issues, and we just have to keep correcting that for life, and then everything will go back to normal. Many clinical psychologists have argued that we might see correlations between cellular activity, structural issues, and mental health problems, but that doesn't necessarily mean that this is a causal thing. A correlation could be a byproduct of other things, like changing thoughts impacting the structures of the brain. And to put everybody on medication when they start manifesting symptoms is, well, not very scientifically rigorous. And we should find ways to really look at an individual on an individual basis before we start rushing to do that. Another thing that this tends to cause is people's not only physical addiction to some of the different drugs that we've been prescribing for mental health issues, but also mental addiction, psychological addiction, this kind of feeling that if we don't take these drugs, things will revert back to horrible places. And oddly enough, with many of these medications, even though they do work very quickly right off the bat, our brains do tend to adapt. So not only do we become addicted to many of them, but our tolerance grows as we progressively take these drugs, and many medications have to be upped, not weaned, as people progress with their problems. And this brings us to this question of what the end result is going to be for people with mental health issues. Do we want people on medication for the rest of their lives? Do we think that's really fixing anything, or is it just masking the problems? One of the best analogies I've ever heard that really suggests that this is not a fix as much as it is just kind of a band-aid was one where people equate kind of individuals with mental health problems as people who just need to kind of have something changed, like a car that's kind of got a broken part. The analogy I've heard is, let's say you've got a car that's leaking oil. So you bring it in to a mechanic and ask this person to help fix your car to prevent the oil from leaking. And this mechanic tells you, let's put a bunch of oil in your car because you absolutely do need it for your car to function. So you do that, and then the mechanic tells you, well, now that we put a bunch of oil in your car, you're good to go. No problems, just make sure every couple miles you pull off to the side of the road and continue putting oil in your car. Well, that might kind of lead you to be a little less confident in this mechanic. It might get you to question whether or not this mechanic really knows what they're talking about. But this is kind of what we do, at least according to most clinical psychologists, when we talk about medication. We're not figuring out, when we start just giving people medication, what the source of the issue is, even if the kind of adjustment of neurochemicals and other things could potentially be kind of helpful. So what's the end result? What's the benefit? Well, many people have argued that this doesn't necessarily mean that we should do away with medication, but we should look to other avenues to try to help individuals, be it either biological or mental in nature. And in fact, when we're talking about biological helps, another thing that's started to emerge over the years is something relating to a topic that we've looked at a couple times in the class. Many clinical psychologists nowadays get trained extensively in biology and genetics because there is this recognition that there is a lot of heritable different types of disorders out there and different types of mental health issues out there that, if we understand genetics better, might be able to flag for and might be able to help people as they start to develop in life, and maybe bring up, tend to increase or decrease their likelihood of developing specific problems. A concept called genetic counseling has become a very hot topic debate over the last couple decades about how we might be able to, when looking at a person's genome, better predict if they have a proclivity for developing anger issues or depression issues or mental health problems, either at their current age or at a later point in life. And what leads to this question of, if we know this stuff, could we develop interventions to help these individuals avoid developing lots of these different problems? It also leads us down a very heated debate about whether or not we should be doing this in the first place, and topics like designer babies and other questions start to be circulated when we talk about looking at sequencing genomes and figuring out what somebody's biology is even before they're born. But it is a path that we've started to explore in clinical psychology when trying to understand all the different biological components that are at play when we look at individuals' mental health. Now, some of you might have noticed at this point that we've spent a considerable amount of time talking about lots of different sources of mental health issues and potential historical components that led us to focus a lot of our attention on the biological aspects of mental health. You might have been left wondering, oh, what about the psychological stuff? What about the things that we tend to link to clinical psychologists? Can we cover those? We indeed can. And in fact, we're going to be covering those a lot over the course of the next couple weeks here. But I wanted to first just give you a kind of a focus on the historical notes of these things and the more biological side of clinical psychology before we transition to talking about what many people in clinical psychology focus their attention on when they're in this area, and something called psychotherapy, an attempt to try to help individuals with mental problems that's really based off of that biopsychosocial model that we talked about earlier, where there's this notion that many of the mental health issues that people are struggling with are, well, mental in nature, and because of it, well, the best way to help these individuals is to address those things. But how we address those things is very multifaceted. There's been lots of debate in the last century plus since clinical psychology started to take shape as to what the best approach to helping individuals with issues is. And what we're going to do in this lecture is just sample, review some of the more prominent approaches that are out there. So if you do move on into a clinical psychology, you can have at least the bases covered and be ready for some of the more nuanced new techniques that have developed in the last couple decades since clinical psychology really started to take shape. So where do we start first then? Well, we probably want to start where clinical psychology took shape in this new realm with what's called psychoanalysis, the approach that was developed by Sigmund Freud based off of his psychodynamic theory. A lot of the stuff that we've discussed earlier with Freud is really prominent in this psychoanalysis approach that really started the clinical discussions on how to help people with mental issues. Freud, again, focused a lot of his attention when looking at mental health on the unconscious world that people had, the drives of the id and the superego, and how the ego was trying to really operate on that reality principle that we discussed earlier. His focus in therapy and people he trained to become therapists was on trying to get at those unconscious thoughts, those memories we had, those desires that were causing a lot of the issues that people were displaying, either things that would qualify as a clinical diagnosis or just things that people would want to help themselves overcome. This led to very extensive, long talk therapy sessions that addressed both past and present desires and weaved its way through the tapestry of different approaches that Freud developed over the years. It became, if we're looking at kind of the context of it, a very diverse, extensive, and expensive approach that many people, if they sought help for the problems based on the psychoanalytic approach, would require years and large amounts of money to be able to kind of see any type of results. But it was the first notes of clinical psychology that started to emerge, and it led eventually to this broad spectrum of clinical approaches that are around today. What was then some pushback to this idea? Well, one of the things that started to become circulated in the early 1900s as people started to embrace the clinical idea, but not necessarily Freud, was an approach that was kind of growing in psychology as a whole that we've talked about before, called behaviorism. Many individuals who focused on the learning aspects of behaviorism started to contend that these same ideas and concepts could easily be applied to individuals struggling with a multitude of different problems, and that we could use a lot of the techniques in behaviorism that we've used to kind of get animals to do things or learn when we talk about how we can get people to think about things differently or behave differently in different situations. The concepts of classical and operant conditioning got often new terms or concepts applied to them, but They, in their new versions, still operated on the exact same behavioral principles that were again being used by these psychologists in a wide range of different areas. Classical conditioning became things like systematic desensitization in clinical psychology concepts. And in fact, there was a champion of this named Mary Cover Jones who spent many years in the early 1900s trying to perfect the craft of using the principles of classical conditioning to help people overcome their strong fears of different things or big issues that they had with different aspects of their lives. We nowadays still have individuals in clinical psychology using a lot of the principles of the behavioral approach in their attempts to help people with substance abuse issues, phobias, and even eating disorders. It's not necessarily one that works perfectly for everything, but the efficacy of behavioral approach is something that has been tested over and over again, and there are such strong, robust effects in certain mental health issues that it's still in circulation today, about 100 years after it was introduced by early behaviorists dabbling in this clinical psychology realm. Another area that started to pick up just a few decades after the introduction of Freud was this thing called the cognitive behavioral approach to clinical psychology. It operated on the assumption that not only were our behaviors sometimes the source of different issues, but so were the thoughts that were going through our heads and the emotions that we were evoking. Many CBT therapists focused their attention on not only addressing what people were doing that was maybe problematic for them, but the things that were going on inside of their heads as they were displaying these behaviors. As CBT started to expand, a large number of different techniques within the CBT umbrella started to emerge. One of the more classic ones that's talked about a lot, and if we were taking this as an in-person class, we'd be watching a video on it, was something called rational emotive behavior therapy. It was championed by a theorist named Albert Ellis, who argued that a lot of people's mental health issues come from the way they react to specific situations. And if we can challenge those reactions to those specific situations, we can help them with a whole range of problems. The classic example that we would have seen in the video is one where a woman talks about how she's very shy and uncomfortable in dating situations. And Ellis, in this interview with her, the woman's name is Gloria, you'll probably see it at some point in your academic career, challenges a lot of the thoughts that she says are coming to mind when she goes out on these dates and when she encounters these things. Now, it's important to note here that Ellis's take on CBT, this rational emotive behavioral therapy, is just one of many different tools and techniques that were developed under this cognitive behavioral realm. And there's new ones that are being developed all the time for a wide range of different issues, possibly because it just goes into so many different things, but also because of the unbelievable efficacy that we see with CBT. Many individuals in the clinical field, especially those that focus on research, tend to, when trying to judge the efficacy of new approaches, compare those approaches almost always to CBT. We tend to call it the gold standard of clinical treatment because it not only works pretty well, but it has a wide range of efficacies that leads many people down the path to essentially suggesting CBT for everyone unless we know there's a tried and true approach that happens to, in that one specific situation, work better than CBT. But much like the psychoanalytic approach, there's a lot of complexity to it. And to truly understand how it works, you have to understand a lot of nuances that takes many years often of training to fully comprehend everything behind this approach. So is there anything else out there then outside of those two big approaches since the psychoanalytic approach? Absolutely. In fact, one of the theorists that we talked about in the personality area also had a big contribution to the clinical world, a gentleman named Carl Rogers. If you remember back to our discussion of him, we tied him to something called the humanistic approach, this notion that people are essentially good and these concepts of selves and self-consistency and self-actualization were really kind of key components to developing who we were. Well, Rogers's take on the self being important and people being inherently good and society impacting us in different ways, not only was used to understand individual differences, but also tried to understand where mental health problems were coming from. Rogers was a huge advocate of bringing people in and having them participate in more of a collaborative approach to helping them with whatever was the source of their different issues. Oftentimes, Rogers called the people he was seeing clients and sought to find ways to measure the efficacy of clinical approaches long before there was a lot of standards for how we could actually do this. In fact, the video I would have shown you with Albert Ellis interviewing Gloria would have then been followed up by a video of Gloria being interviewed by Carl Rogers and having him display his mental health approach, called the humanistic approach, or sometimes called the client-centered approach, that he, again, pushed and tried to find ways to verify if it worked through things like his use of Gloria and other clinical approaches over the years. It's really important to note here that much like the social cognitive approach, the cognitive behavioral approach, mixing terms up, the cognitive behavioral approach, that this idea of Rogers is still in circulation today, and it's expanded into a large number of different areas where even if people aren't necessarily saying they're using the humanistic approach, there's nuances and elements of this humanistic approach embedded within those techniques that Rogers developed almost over 100 years ago at this point in time. This might lead you to think, well, then what's the kind of new trends that are out there if we're talking about people that have been around for an extended period of time? Well, nowadays, more often than not, when clinical psychologists come up in the world, they're no longer trained to just be specialists in one particular area of clinical psychology. There are the occasional people that will say, I'm a psychoanalyst, or I'm using the humanistic approach on everybody, but more often than not, people in clinical psychology today get trained, if they are going to go down the therapeutic route, on numerous different approaches that are out there, and they tend to try to figure out the best way to help individuals based on kind of the data that's available and the things that seem to resonate best with the person that they're working with. And this has led to the development of not necessarily lots of new philosophies on clinical psychology, but new takes on how to help individuals best. One of the things that's been around a lot in recent decades is this approach called brief therapy, something that is sort of byproduct of this kind of growing notion that people can help themselves and work on things, but also this kind of growth in the medical world where drugs are so commonly prescribed and clinicians are so unbelievably unavailable that really brief therapy is kind of both a philosophical idea and a situational need that has filled a lot of gaps in the clinical world that seem to exist nowadays. In brief therapy, clinicians don't see somebody, say, once a week or multiple times within a week like it's sometimes suggested, but instead they'll see individuals once a month or so, or even less than that, just going over what things have transpired over the course of the time where these clinicians aren't seeing the individuals, coming up with a plan for what could happen in the future time, and really just checking in on things like if meds are working, or if the things that they've tried to do are effective enough, or if something needs to be tweaked. This approach is something that's been circulated a lot recently in hospitals and other major carriers and providers, simply because there's really very few other alternatives out there. This is also the same with some of the other techniques that have started to be kind of gaining in prominence over the last few decades. Group therapy, something that has been around for quite some time, even though there's lots of debates as to whether or not it helps, is something that has grown and grown over the last few decades. In group therapy, the idea is that you have one therapist and multiple individuals struggling with similar problems that all seek help at the same time. Advocates for it argue that the collaborative nature of group therapy and the ability to see others with similar problems can actually be very helpful to certain individuals. And there is data that does support this notion. There's questions as to whether or not this is as effective as one-on-one therapy. whether or not people would be better suited seeing an individual therapist if they have that option. But again, due to the times and the rates of efficacy that we see with it, this is something that's grown in popularity recently. The same can be said for self-help groups, which have been around for many decades, but are gaining in prominence across a wide range of different things. Self-help groups historically have been tied to mental health issues that have proven to be very challenging for clinical psychologists to tackle. The classic self-help group that people often reference is something called Alcoholics Anonymous, or AA. This self-help group is still around in circulation today, but some of the components to it are not necessarily similar to the ones that we see in other self-help groups. AA's early insistence on having some type of spiritual connotation to it and kind of religious aspects that are incorporated into the approach is not something that we see in all self-help groups. And in fact, some of their things like chips and sponsors, techniques that they have, are not found in many self-help groups that are around. The one underlying thing that is consistent within all self-help groups is that there is, again, interaction with individuals struggling with similar problems, but in this case, what makes it different from group therapy is that the therapists themselves are sort of taken out. There's usually individuals that lead these groups. Usually it's people who have gone through similar problems and have kind of gotten to the point where they feel like they can help other people out. But the essence of group therapies can be found in self-help groups with those kind of minor tweaks that we talked about. And again, if we're looking for the newest trends, the things that are popping up, there's lots of specific techniques that you'll learn about in the future and if you do pursue a degree in clinical psychology. But know that, again, many people in this field tend to be trained in lots of different techniques. That's why many individuals tend to call themselves today integrative psychotherapists. Technically, in the past, this approach was called eclectic therapy, but many people from clinical psychology have steered away from that term because integrative psychotherapy gives this impression that these people have been trained in lots of things and they can adjust to the person and the situation really well. Eclectic therapy is given this impression that essentially clinical psychologists aren't really trained well in anything, so they just learn a little bit about everything and throw whatever they can at somebody hoping that something sticks. It's definitely not, hopefully, if anybody goes and sees a clinical psychologist, a pervasive trend in clinical psychology today. Most people who do really get trained effectively learn a lot about a ton of different approaches that are out there and new techniques that have developed. And this is still, even to this day, a growing profession with lots of new techniques and approaches trying to be developed, either off of some of the early ideas that we've talked about before, or some of the new techniques that are picking up in popularity. And all of it really highlights how, when we talk about helping individuals with psychological problems, there's a lot of different avenues that you can pursue, both in the biological world and the psychological world. And kind of getting, I guess, an introduction into the wide expanse of clinical psychology is what I was hoping we could accomplish today in this class. And hopefully now that we've gone through all of this, you have a little bit more clarity on what clinical psychology entails. Maybe we've dispelled some misnomers about people seeking out therapy or mental health issues in general. In the next couple classes, what we're going to be doing is diving into specific mental health issues that qualify as diagnosable disorders, so we can, again, continue to explore this area of clinical psychology better, and hopefully, as you're leaving, dispel some of the preconceived notions that many of us carry with us getting into this field. It's going to mark the end of today. I hope you enjoyed the lecture, and hopefully I'll see many of you soon. Take care.